Thank you for this kind presentation. I don't speak English, I don't speak Spanish, so I have to present in English. So for reason of time and also due to my experience, which is more clinically based, we will focus on the clinical aspect and issues of some superficial vascular tumors related to diagnosis and therapy, considering the past, the present, and future. And we will underline the use and the contribution of imaging in the diagnosis of these vascular tumors. So, as you know, in the classification, we divide superficial vascular anomalies between vascular tumors and vascular malformation, and there is a clear distinction between malformative entities and true tumor lesions, and the prototype is the infantile hemangioma. As illustrated in this nice paper by Christine in the Lancet, the hemangioma are really proliferation and differentiation of cells induced by angiogenic factors, and hypoxia is considered as the main trigger of this activation. However, I remember 15 years ago, I was embarrassed by this case. We are also a national reference center for malformation of the cerebellum, and I had this case referred for hypoplasia of one hemisphere here. And after birth, this appeared, and I didn't see the link at that time between this hypoplasia and this. And at the same time, Metri published the face syndrome with the large plaque-like segmental hemangioma of the face with associated malformation, as you know, posterior fossa brain malformation, cerebrovascular anomalies, cardiovascular anomalies, eyes anomalies, and sternal cleft. And it was an unknown etiologies and pathogenicity, and it's still an unexplained association between segmental tumor lesions and true malformative lesion. So this distinction between tumors and malformative entity is in some case unclear. And we published a series of 26 cases prenatal diagnosis of focal reduction of hemisphere, and in 4 cases it was a face syndrome as illustrated in these cases. So the prenatal diagnosis of face may be possible. Is it worthwhile to do the prenatal diagnosis of face syndrome? It's difficult to answer this question, and especially if the polygon of Willis is incomplete on Doppler analysis. And this is a very impressive case. This baby has a face syndrome, and the cerebral vascular supply is only due to one vertebral artery. There is no carotid artery. The right vertebral artery is missing, and there is a very tortuous basilar artery. So all the vascular supply is due to this vertebral artery. And this baby is now 8 years and is doing well. So you know that there is this consensus statement of the criteria of face syndrome. We just speak about this article just before. And in fact, there is also new report features as deafness, dental problems, hypothyroidism, and no significant cognitive issue. But in our series, we have 2 cases of autism. Is it fortuitous or not? We don't have the answer. Maybe you have some cases like that, and I will be very interesting if you have some cases of autism with face, and we have 2 cases like that. So what about also the reality of evolutive, occlusive, or static encephalic arterial lesions? Because in our experience, we don't have this kind of evolution on the lesion on the artery of the brain. So, as you know, oral propranolol was a real revolution in 2008, as said by Alain just before. But before 2008, the first line was steroids. And there is this rules of the third of Odile and Enjolras in France. In 1/3 it works, in 1/3 it doesn't work, and in 1/3 there is stabilization of the angioma. But there is also many side effects of this long-term steroid therapy, and this is the case I just showed you, and this case was treated by long-term steroids, and because of that, the patients developed early severe growth restriction. And we discussed with the endocrinologist, and they decided to put this baby under growth hormone for this severe growth restriction. And this is the baby 3 weeks after the growth hormone initiation, and it shows that for sure hemangioma is a true tumoral lesions because there is increase in the turnover in cells with the worsen of the hemangioma. And with hemangioma, for sure, we don't have this kind of complication. This is for sure a true evolution, and you know of that by heart, this paper and this one. And you know that this trial showed that propanol is effective, and the patients were between 1 and 4 months of age. So what about late initiation of oral propanol treatment? Are there any criteria to assess potential response to propanol therapy? In our experience, we use a lot color Doppler ultrasound. I'm a radiologist, I'm the coordinator of the consultation, and I do both consultation, and during my consultation I can do ultrasound, and for us it's a very useful tool. I will show you 2 cases. This one was referred for us at 40 months of age. This is a patient from Lille in the north of France, and they asked, is it worthwhile to do propanolol in this case? And some dermatologists say it's too late, so we should do that before. I don't know what you think about this case, and in fact the answer can be with ultrasound, because this is this mixed hemangioma, and there is echogenic lesion, which is fatty transformation of the hemangioma, but when you do Doppler, there is high vascularization. That means that this lesion will answer, you have a good response with hemangioma. And we did that, and this is the baby 4 months after initiation of propanolol. And this baby can be operated with minimal scarring before entering to school, and with minimal hemorrhage because of the hemangioma. So of propanolol. So this is a good case for hemangioma, sorry. These patients refer at our consultation at 1 year for a large hemangioma of the left labia majora. You see, and when you see this kind of hemangioma, you want to do something. And however, with ultrasound, there is almost no vascularization in this lesion. That means that almost all the lesion is now fatty, is fat. And we initiate the treatment just for the parents, but we were sure that it would not work. And this some weeks after, there is no real modification, and this patient has there is no interest for this patient to treat this hemangioma with propanolol. So, in our experience, color Doppler is a very useful tool to assess potential response to propanolol, but also to assess risk of relapse after stopping therapy. You know, with the Lancet and with other paper, the risk of relapse is between 10 and 15%. And when we do the ultrasound, if there is some vascularization, still vascularization in the lesion, we are sure that we will have a relapse when we stop the treatment. So for us, it's a real useful tool to guide how to treat the hemangioma. I should say, you have to be very careful when imaging is used for diagnostic purpose in case of these vascular lesions. And imaging data should be correlated with clinical features, and in case of any doubt, biopsy should be discussed to avoid any misdiagnosis. Why? Because these are refugees from the East of Europe, and it was referred for us some years ago for evolutive exophthalmia. And we cannot discuss with the family. So we don't know when it happened. It seems to happen very quickly, and at that time we have a CT scan performed not in our department, and there is for sure lesions, highly vascular lesions, and with Doppler it was real vascular. It was solid vascular, and at that time we initiated treatment with steroids and asked to see the baby 2 weeks after. And because of personal reasons, they came 3 weeks after initiation of the steroids therapy. And this is the baby 3 weeks after. And we did an MR. There is still a high vascular lesions, solid lesions, and with the ultrasound, it's solid, very homogeneous. There is a lot of flow. It looks like an hemangioma, but when we did the compression, it was a sarcoma. So be aware that some cases can mimic, in fact, an hemangioma, and it's rhabdosarcoma or also some embryonic sarcoma. This is important in deep lesions. Indication of treatment. You know off by heart this indication. What about ulcerated hemangioma? For sure, it's a good indication, but we have some cases like that. This is a mixed hemangioma with some onset of ulceration in the middle and the lightening of the lesion here. So we initiate hemangioma in that case, and this is 10 days after, and you see there is a worsen of the ulceration. And we have 4 cases like that. Another case, small ulceration, so good indication for hemangioma, but we saw the patient 3 weeks after. Look at the ulceration. So I don't know how to manage this case. In our experience now, we prefer to begin directed healing for a few days before initiating oral propranolol, but I would be glad to have your answer about this kind of ulceration and worsen of the ulceration under treatment. So give me the answer. Congenital hemangioma. Is there any affiliation between rich, niche, and pitch? And Michel Basseff is here, had an hypothesis. It may be one entity with 3 different evolution over time, and he showed us this slide in Argentina. Because we have experience of prenatal diagnosis of this hemangioma, our experience does not really support this hypothesis, because we have no case of prenatal diagnosis of rich with a clinical appearance of niche at birth. So what about rich in the prenatal diagnosis? It's diagnosed in the late second trimester or third trimester. It's solid, often heterogeneous, well-circumscribed bulging lesions with often small echogenic foci suggestive of calcification. And there is vascular structure on Doppler analysis, and sometimes you have large arterial feeders and large venous lakes. And when you have large feeders and lakes, you have a high risk of high flow cardiac failure. And you know the the location, skull and periauricular regions, and we have published that there is a characteristic sonographic features which is thin hyperechogic line over the lesion, which is the periosteum, and it suggests that it's a sub-periosteal origin, and because of that it can lead to a mass effect on the underlying skull, and it can be very impressive for the gynae who did the ultrasound. This is a case. You see it's on the occipital area, and you see this line, it's the periosteum, and this is the hypodermis. And this is, in fact, a sub-periosteal origin, and it can give you a mass effect on the vault, which can be very impressive, as in this case, you see there is a mass effect, which is very impressive on the MR. but you don't be concerned by this mass effect, because there will be a correction of the mass effect after birth when the lesion will decrease inside during the first year. You know also the location, which is near the limb, on the limb near the joint, and the differential diagnosis is congenital fibrosarcoma. This is a case with lesions close to the left elbow. You see there is some vascular structure, and it was a very high vascular lesions, and because of that there is cardiomegaly and a beginning of high flow heart failure in that case. And this is a baby with the MR. You see it's in the hypodermis, not in the muscle, and it's very circumscribed. And this is the baby at birth. And you see some tiny foci, which has calcification, which are very common in this kind of lesions. And the baby 2 months after, and it's a classical evolution. But is all wish have this kind of good outcome? What do you say when you see this kind of reach? You know that there is a necrosis. What will happen when the necrosis tissue will fall off? It depends on the underlying tissue. On this case, there is a large artery coming underneath the necrosis. And in fact, this baby was brought to the emergency with a hemoglobin of 3 grams, close to death, because there is a very important hemorrhage during the night with this baby. So we should be aware when there is a necrosis or some fragility of the skin, like in this case. We show this case 3 months ago. You see there is a sort of erythematous scarring on the thigh, and this is the ultrasound here. You see it's tissue for sure, highly vascular, but when you go close to the fragility of skin, you have this and a large draining vein, and just underneath this there is a large lake, vascular lake. So what will happen if there is a necrosis of something here? So you should be aware and be conscious that there is some wish at risk of hemorrhage, and you have to do an ultrasound to be sure that there is no large lake underneath the skin. Some recently described vascular tubular entities needs maybe a more complete phenotypic description to be complete with a complete spectrum. You know there is some unclassified lesions, and some of them are the MLT or CAT, multiple lymphangiosarcomatosis with thrombocytopenia, published by Paul North in 2004, and the years after, a series of 10 cases called cutaneous visceral angiomatosis with thrombocytopenia, the same entity, but in that case, it was 10 children with congenital multifocal cutaneous lesions, with, in all patients, involvement of the GI tract. There is also a thrombocytopenia and involvement of other organs, lung, bone, liver, spleen, and muscle. But the phenotype is maybe larger than initially described. These are patients with 5 congenital large red-blue lesions involving the trans, upper extremities, and a retroauricular area. You see, it doesn't look like an angiomatosis, classical infantile hemangioma. And if you look at the lesion, there is almost no flow within these lesions. So it's not for sure an infantile hemangioma, even if some lesions look like small infantile hemangioma. But these patients have also multiple visceral lesions in the kidney, in the adrenal, with almost no flow in the lesions, but also in the lung and in the wings, here, in the muscles, and in the brain. And there is nothing on the GI tracts, on the endoscopic exploration, no thrombocytopenia, but the biopsy was compatible with multifocal congenital lymphangiosendoteliomatosis, and this case was seen by Michel Vasseff with a favorable outcome. And we have two cases like that. The other has a number of lesions in the CNS. So this may be compatible with this multifocal congenital lymphangiosendoteliomatosis without gastrointestinal bleeding or thrombocytopenia. So the spectrum may be larger than initially described. Now, intramuscular capillary type hemangioma. This intramuscular capillary type hemangioma will soon enter in the new edition of the ECSVL classification. But what are the typical features of this hemangioma? We have a poster in Malmö some years ago about the clinical and imaging findings of this hemangioma, and it's always in the muscle, in the thigh here, in the posterior part of the thigh. You see it's very heterogeneous with echogenic lesions, which are fat most of the time, with high flow lesions, with a high resistive index, which is not like AVM, and there is enhancement after injection. And we report the findings: large, well-demarcated lesions, echogic solid heterogeneous lesions, high flow lesions, heterogeneous with fatty component, and for sure there is also some artery coming in the lesions. And the differential diagnosis is AVM, and it's an important issue regarding therapy. And these features are similar to those described in a recent paper by the Boston team about intramuscular capillary type hemangioma with a painless mass, well circumscribed, heterogeneous lesions with flow voids, with fatty components, and with large arterial feeders and inhomogeneous parenchymal staining, but without direct AV shunting. However, some intramuscular capillary type hemangioma can mimic AVM if arterial feeders are overdeveloped. This patient is now 10 years old. It was referred at 2 years for anesiomelia due to high flow lesions involving muscles of the posterior component of the right thigh with high velocity flow with low resistive index. He had an angioscan which shows that this lesion was fed by branches of the deep femoral artery with early venous drainage. And this lesion was located in the biceps femoris, but also in the semimembranous and semitendinous muscles. This is the angioscan. You see that there is an artery which is enlarged with early venous drainage, and the muscle is involved, and there is staining after an enhancement of the muscle, and with the angioscan, it looked like AVM. You see, there is plenty of arterial feeders in these lesions. But when you do the MR, you have a well circumscribed muscular lesions on T1 and T2. This is these lesions, which is well circumscribed. You will not have this kind of lesions with AVM. It's not like this. It involves the muscle, but you don't have a mass like that. And after injection, you get the same kind of enhancement in this muscle, but also in other muscles here. There is a surgical biopsy, which was very hemorrhagic, and the initial diagnosis was AVM. there is a second look by Michel Vasseff. We say that it was an intramuscular capillary hemangioma, and it was our diagnosis on the basis of imaging. And this is the histology. I will not comment on that. Michel, you say that it was intramuscular hemangioma. So what we did a partial excision of the long femoral biceps muscle after pre-surgical embolization, and the post-operative event was excellent, with excellent evolution with correction of the anisomelia. This is another case. We fear for AVM of the forearm. He had elastic compression. It was mildly symptomatic till the age of 15, and he had angiosity at 16 with the high flow lesions fed by branches from the radial and anterossus artery. You see this lesion. It can mimic an AVM for sure. You see the return venous flow and the arterial flow. They are very developed, and this is, in fact, the 3D images. This is very characteristic with the MR, well-circumscribed lesions with very large artery, which mimics the AVM. And this is the angiogram, and you see there is maybe some very tiny fistula because there is early venous drainage, but it's not an AVM. And in that case, we did an embolization, and it was for the patients a significant improvement of the symptomatology after 3 embolization with onyx. So some intramuscular capillary type hemangioma can mimic AVM if arterial feeders are overdeveloped, and it's an important issue regarding therapeutical management. So to conclude, we did major efforts in the last 20 years for better understanding and classification of superficial vascular lesions. Still, numbers of questions regarding physiopathology, diagnosis, follow-up, and treatment. There is for sure an importance for multicentric studies, and European studies are mandatory. And there is a major input of the ESSVR, and there is a major increase of membership over the years. But there is also importance of local national society, such as your very active Spanish groups, and we'll be happy to collaborate, the French group and the Spanish group, but we know that you are very far away at that time compared to what we did in France. Thank you so much for your attention.